Good evening, all the members. Welcome to our yet again Wednesday webinar by Young Minds. Now today we have Dr. NIHAL, who is very young, dynamic, academically oriented, committed to this society activities. He's going to talk on treatment-resistant depression, challenges and strategies. ఒక మాటలో చెప్పాలంటే తండ్రిని మంచిన తనయుడు అవుతాడు ఈయన డెఫినెట్ గాను. సో లెట్ us encourage him, and I request Dr. Ramanrao garu to chair the proceedings.
Thank you, IPS garu. Thank you very much, sir. Today Dr. NIHAL is going to speak on a very important topic, which is treatment-resistant depression. And some people call it as difficult to treat depression because term TRD indicates therapeutic nihilism, and patient-doctor relationship sometimes may be a little bit strained because of these terms. So some people call it as difficult to treat depression. I think that is a better term, but still the TRD is the accepted term. As we know, the definition of TRD, any patient with a depressive disorder where two trials with conventional antidepressants belonging to two different classes for a duration of 2 weeks each, if it failed, then we call it as a treatment-resistant depression. In the classic study, it was revealed that almost 1/3 of the patients belong to this group. And I'm sure that NIHAL is going to enlighten us about difficult strategies or different strategies to mitigate the suffering of such patients. And as we know, ECT is the gold standard in most of the cases. But unfortunately, in one study, it was found that only 0.25% of the patients they were administered ECT. So this indicates that ECT is the most underutilized procedure, even though it is the gold standard in the treatment of treatment-resistant depression. Then comes the augmentation therapies with the lithium, T3, and the second generation antipsychotics. We also know that combinations like SSRIs and SNRIs, though sometimes some people call it as irrational combination, and we have combinations like SSRIs and NASA, and so on and so forth. Most promising of all these therapies of late is the intermittent theta burst as well as the nasal esketamine. So with this very brief introduction, I request our chairperson, Dr. Ayodhya garu, to take over the proceedings. Thank you.
Good evening, everybody. Good evening, everybody. Thank you very much for this opportunity given by the IPS CAP committee. It's a very good and interesting topic today. We are going to have a discussion on treatment-resistant depression. Almost every psychiatrist during their practice or during their services, they used to see very commonly, and sometimes we used to fight against this TRD with so many things, augmentation, switching over to another molecule and another antidepressant, and most of the somatic treatments. So nowadays we are seeing RTMS, and in the experimental stage, deep brain stimulation, magnetic seizure therapy, so many things, and even ablative limbic surgery also. But people have to get benefit out of practical things, not from the experimental things. And I welcome Dr. N.G. NIHAL, who is a young dynamic psychiatrist from Visakhapatnam. He completed his MD in Mamta Medical College. He is a consultant psychiatrist in Kausalya Counseling Center, Visakhapatnam. He is a co-chairperson of IPS Young Psychiatrist Subcommittee, and he is a peer reviewer for Archives of Mental Health, IPS AP Journal, Telangana Journal of Psychiatry, Telangana Journal of IMA, and he is the member of communication team IPS AP, and awarded World Psychiatric Association 2022 Early Career Psychiatrist Fellowship also. And he got the second prize in paper presentation at the 9th World Congress of Asian Psychiatry, Hyderabad. And he gave so many contributions, almost 10 publications and presentations of his research to different things. Nihal is a young penetrating psychiatrist. I hope he'll give a very clear picture of how to deal TRD, because it's a burdening thing on the patient and the caregivers and family members also. The most important, the quality of life in this TRD people we are seeing. Nihal, please welcome.
Thank you, sir. Thank you for the warm introduction. I would like to share my screen. Because in general, it is accepted that although the antidepressant medications can be effective in treating major depressive disorder, but they fail to achieve remission in approximately 1 out of 3 patients, and 30% of the patients are resistant to the conventional treatment. Like as also like Ramana also mentioned, the study trial was mainly conducted to determine the most effective treatment for individuals with MDD who had an unsatisfactory response. In the study trial, if you look at in the first stage, the citalopram was selected due to its low risk of discontinuation related side effects. Those who couldn't achieve remission with citalopram, they were shifted into the level 2, where the medications were selected to test the interclass and the intraclass of drug. The interclass of drug was a sertraline, which was an SSRI like citalopram. The interclass was the bupropion and venlafaxine. And the patient also had a choice with CBT or in combination with citalopram or bupropion or buspirone. Now, after this, even patient who didn't achieve remission was shifted to level 3, in which they were tried with adjunctive lithium or T3, or they were switched to mirtazapine and or not tripling. Again, at this phase when the patients who didn't achieve remission, they were shifted to the MAO inhibitor, that's transcypramine, or the mirtazapine or plus the venlafaxine combination, which is commonly called as the California rocket fuel was given. The cumulative remission after 4 trials in the study, after 4 trials of the study, was about 67%. Even after sequential treatments, still 10 to 20% haven't been completely cured after 2 years or longer. Now, coming on to what is TRD. To be very frank, we seriously don't have a not definition, we don't have a standard definition of TRD. The reason being, each one of them proposed different definitions for TRD. The FDA or the EMA, most of them have said to failure of 2 antidepressants, but the Tace and Rush model or the Modular model says that at least failure of 1 antidepressant. The required number, as I said, the required number of treatment failures varied from each of the proposed ones. Some proposed models have also considered the failure of ECT as a part of treatment-resistant depression. It's a different class of antidepressants, and different comorbidities like anxiety, personal disorder were also considered. As the definition has been varying from each of the proposed models, the prevalence of TRD cannot be defined properly. If you can look at the table, almost all the proposed definitions ignore the role of psychotherapy. Now, are these guidelines indirectly saying there isn't much role of psychotherapy in TRD? Well, that is really debatable. Now, in today's webinar, we'll be considering TRD as unsuccessful to adequate antidepressant trials. Irrespective of the time period. The National Mental Health Survey reports that the prevalence is around 2.7% for the depressive disorders. The various stages of the TRD have been proposed by different models. One among them was the antidepressant treatment history form, where the various questions regarding what all antidepressants used will be given, and based on that, we'll be calculating the severity. The other model is the Tesh and Rush staging model, where it is divided into 5 stages. In the first stage, it is the failure of at least one adequate trail of one major antidepressant. The second stage is 2 adequate trails of two different classes. And stage 3 is again that inclusive the tricyclic antidepressant. Stage 4 that includes the MAO inhibitor. The stage 5 includes the ECT. The other staging model is the European staging model, where it classifies into 3 parts. That is the non-responder, the treatment-resistant depression, the CRD, that is the chronic resistant depression. The other proposed, the other given models were the Massachusetts General Hospital staging model and the Maudsley staging model. Now, what are the challenges do we have while diagnosing treatment-resistant depression? The first thing, exclusion. Exclusion is the crucial step. The pseudo-resistance may include with suboptimal doses of antidepressant or had an early discontinuation of medication that could lead to pseudo-resistance, but we consider it as accidentally as a treatment-resistant depression. The second challenge we have is the comorbidities that are present along with the depression, that is the anxiety disorders, the personality disorders, or the substance use disorders. Now, these comorbidities can complicate the clinical picture and can have deleterious effects on the treatment response. And the third challenge we might be having is the potential for recall bias when starting the medication, and response adds a significant layer of difficulty in diagnosing the treatment-resistant depression. Now, for that, the antidepressant treatment history form can be useful, which consists of scoring instructions and ratings for most of the antidepressants and ECT trails. Now, this history form has been used to determine the adequacy of the antidepressant trails. Now, coming on to predictors and the risk factors of the treatment-resistant depression. Now, this has been taken from a systematic review, the recently published systematic review, which says that most of the studies have cited that those with greater depression severity, suicidality, long duration of treatment-resistant depression, or recurrent depression had more tendency to develop treatment-resistant depression, along with comorbidities with by anxiety disorder. And interestingly, they said that the higher levels of neuroticism has been linked to development of treatment-resistant depression. Now, based on symptomatology, there was a study with a national survey done in China among 1,151 depressive patients, where the first episode of depression and the BPA current depression were excluded. That means those who are on recurrent depression. Now, this study has said that the patients presenting with more of somatic symptoms had a higher risk of developing treatment-resistant depression. And the study also mentioned that almost in their study, the 11.1% have had treatment diagnosed as 11%. The prevalence was 11.1%. How do we approach to treatment-resistant depression? Before approaching to treatment-resistant depression, once you diagnose depression and the severity of it based on the assessment scales like the BDI or the Hamilton Depression Rating Scale, accordingly you start the medication. Our IPS guidelines says that if it is mild to moderate, you want to start either the psychotherapy or the pharmacotherapy. If there is no response, you're going to change the medication or choose an alternative psychotherapy. If there is a partial response, you need to increase the frequency of psychotherapy or increase the dosage to the maximum tolerable dose. If still there is no response, then you need to add the second antidepressant, and by now or by then only 50% of them improve. Then after that, you need to reassess the diagnosis whether the patient falls on depression or not, based on after the first diagnosis, whether the patient falls on depression or not, or the patient has received, if the patient falls on a depression, if the patient had received adequate doses for the adequate duration of time, or the patient was adherent to the medication properly, or there were any side effects. If all the and also you need to look out if there were any organic causes. If all of them are ruled out, then you need to consider diagnosis of treatment-resistant depression. Once you consider the diagnosis of treatment-resistant depression, our IPS guidelines say that you either need to start with a combination of antidepressants, probably the tricyclic antidepressants or the SSRIs, plus SSRIs, or the combination of bupropion plus SSRI. If not that, you can try augmenting the current antidepressant with lithium or thyroid or buspirone, or you can also try with other like lamotrigine or metazapine bupropion combination. If all of them fail, the last resort is again the neuromodulation techniques. Once the patient recovers from the treatment-resistant depression, patient goes into the continuation phase where the patient is advised, our guidelines says that continue the medication at that particular dose for at least 6 to 9 months after achieving remission. Again, we initially start with the SSRIs or the SNRIs. The SSRIs also, in our country, we generally start with either with the escitalopram, the fluoxetine, the paroxetine, or the sertraline in the SSRIs. Whereas in the SNRI, we start with the desvenlafaxine. The SSRIs generally take around, not the SSRI, most of the antidepressants take around 2 weeks between the start of the treatment with antidepressant drugs and the onset of their clinical antidepressive effects, particularly the SSRIs. The optimal duration advised is at least 4 to 8 weeks before changing the drug. The SNRIs, as I said, the venlafaxine, desvenlafaxine, the desvenlafaxine is mostly preferred, and the other drugs that can be tried are the SPAREs or the NASA or the NARI or the NDRAs. Almost all the antidepressants need 2 weeks for onset of action, but the metazapine takes around 1 week to act, which is quite earlier than compared to rest. Coming on based on the clinical dimensions, a very few have released guidelines for treatment-resistant depression. Now, this one, the one you're seeing on the screen, is formulated by the French Association of Biological Psychiatry. Now, these say that based on the clinical dimensions, these say that the initial drug that has to be started is the SSRIs or the SNRIs. If they don't work, then you can try in the second intention as the alpha-2 antagonists or agomelatine or the tricyclic antidepressants. But even the Egypt guidelines also tell the same, but with few changes. For example, if you take of patients suffering with marked anhedonia in the treatment-resistant depression phase, they advise to use the NDRIs, or the patients suffering with marked psychomotor retardation, again, they advise to use NDRIs and or the SNRIs instead of the SSRIs. And also with patients suffering with anxious features, they advise it as a first choice, the SSRIs, SNRIs, along with metazapine or the lithium. Either of the 4, you can start one. Coming on to if the antidepressants doesn't work, the next resort we look up to are the antipsychotics, especially at the low dose, as the second generation antipsychotics are known to have some effect on the serotonin receptors. Therefore, they're believed to have an effect too while in augmentation. So in generally, we're gonna start most of start with the aripiprazole, the low dose, or the combination of olanzapine and fluoxetine, but the others that can be tried are the quetiapine, the risperidone, and the ziprasidone. The other drug that has been recently launched is the cariprazine. The cariprazine also has the FDA approval for adjunctive therapy for the major depressive disorder. In fact, cariprazine is the 5th second-generation antipsychotic to receive FDA approval. The previous one that received were the olanzapine, the quetiapine, and the 3rd-generation antipsychotic, that is aripiprazole and the bexpiprazole. The advised dosage is around 1.5 to 3 mg. The side effect, the commonly seen side effect is ectasia, which is very commonly seen. If not the other side effects that are not most commonly seen are the vomiting, nausea, and the restlessness. Based on I could find 2 studies, interesting contradicting studies. One is the randomized control trial, and the other is the case series. The randomized control trial was conducted for 3 years, where the 1/3 of the patient have received placebo, the other 1/3 received cariprazine 1.5 mg, and the last 1/3 has received 3 mg. But the findings were surprisingly, they couldn't find differences between the cariprazine and the placebo on the primary or the secondary outcomes. But in the recently published article in the Frontiers of Psychiatry, where a case series of 10 patients who already failed in the augmentation trail with the second generation antipsychotic which were risperidone, the aripiprazole, or the brexpiprazole, either of the three, one of them were used where patient couldn't show any much response to it. But when started with cariprazine, it was observed that like 7 out of 10 patients have recovered, had met the criteria for clinical response, out of which one have shown response at the second week itself. At the second week itself, it means only 3 patients couldn't recover with cariprazine. The other drug is the lithium. Even the Egyptian guidelines have proposed lithium as a first-line medication for the treatment-resistant depression, especially in mood disorder and those having with anti-suicidal effects. Among many augmentation options, the lithium obviously stands out because of its efficacy in preventing the relapses and recurrences of mood episodes. That's a reason why that could be a reason why the American Psychiatric Association and the World Federation of Society of Biological Psychiatry strongly recommend lithium as an effective augmentation. The lithium also has the biggest advantage is the anti-suicidal effect, and it is also less expensive compared to the other antidepressants. The only issue with lithium is that you need to monitor every 3 to 6 months. But the effects of it is advised to start the lithium on 300 mg BD, and the dosages can be adjusted upwards based on the lithium levels. The effects of lithium augmentation might appear within 10 days after reaching the study level of the target plasma concentration, but for an adequate rate, it is advised to use at least 2 weeks of the lithium. Now, when do you need to consider lithium, especially in those with patients with suffering with psychomotor retardation, weight loss, increased suicidality, recurrent depressive episodes, family history of mood disorder, or had a good response with ECT earlier? Now, but lithium was found to be less beneficial, especially in patients with atypical features or were resistant to multiple treatment options. What side effects do you see with lithium is again generally it is the tremor, the GI discomfort, the weight gain, the hypothyroidism, the hyperparathyroidism, diabetes insipidus, and the lithium nephropathy. This is regarding the medication of the pharmacological medicine. The other reported treatments for in TRD were the amantadine, Ayushka, buprenorphine, the cabergoline, the dextromethorphan or plus quinidine combination, the methylfolate, the hyoscine, the ketoconazole, the modafinil, nimifetide, nortriptyline plus lithium combination, the estrogen, the omega-3, which is commonly used, the pendolol, the adenosylmethionine is also commonly promoted by the pharma companies. The stimulants like methylphenidate, the testosterone. Interestingly, even zinc had one RCT trial that showed good results in refractory depression. But out of all this, the interesting one is the pramipexole, which I could find many studies, but in this study, the pramipexole was given in 116 patients, where out of which 37 were treatment-resistant bipolar affective disorder currently and depression, and 79 were diagnosed as treatment-resistant depression. The finding was after 24 weeks of using pramipexole augmentation, almost 74.1% have responded and 66.4% have remitted. In fact, in this study, none of the patients while using pramipexole had a suicidal attempt or suicidal ideation or needed hospitalization. And the beneficial effect of the pramipexole might be attributed due to its stimulation of D2 receptors. Now, coming on to when all the medications fail, the alternative or the last resort option is always the neuromodulation techniques, where like we have the various neuromodulation techniques like the ECT, the RTMS, the magnetic seizure therapy, the deep brain stimulation, and the vagus nerve stimulation, out of which ECT is most common in the country, but still, it has stigma, but which is followed by RTMS. As I said, like ECT is the best established as the best therapeutic option for TRD, but again, the neurophysiological mechanism is yet to be properly known. the ECT has been already proven as highly effective in acute and maintenance of treatment-resistant depression, but it also has limitations, citing stigma or lack of acceptability in many patients, and also the memory deficit that occur. So but the alternative to ECT, the other neuromodulation is obviously the RTMS. RTMS is, as it is being a non-invasive, it is more acceptable than ECT, but the limitation is it is inferior to ECT. It is not as effective as ECT. The recently approved one was the vagus nerve stimulation. But the vagus nerve, it was also an FDA approved procedure with a history of at least 4 failed antidepressants. But again, the limitations are the complications of implant, the cost of treatment, and the complexity of procedures. What are we looking out for? The upcoming antidepressant that could be promising in the treatment-resistant depression. One is the esketamine, the zepirone, the zuranolone, and the brexanolone. Coming on to the esketamine was FDA approved in 2018. It is an NMDA receptor antagonist. The terminal half-life is around 7 to 12 hours. It is advised it is to be given intranasally. The induction phase is 56. In the initial phase, is 56 mg twice per week. In the maintenance phase, it is 56 or 84 mg once per week for 9 weeks. The onset of action is very quick, which is within 40 minutes. The side effects are dissociation, sedation, anxiety, short-term cognitive impairment, dizziness, just like ketamine. But the contrary, it is not advised to be given in the aneurysmal vascular disease, and it's also not recommended in hepatic impairment. The esketamine is advised to be given as an adjuvant to antidepressant. The other one is the zepirone extended release. This is an oral drug that is advised to use after food. The initial dosage is 18.2 mg that can be increased up to 36.3 mg on day 4, 54.5 mg on day 7, and 7 can be increased up to 72.6 after an additional week. The believed mechanism is that it selectively targets the 5-HTA receptor. Selective agonism on the 5-HTA receptors is the believed mechanism, but the side effects are the dizziness, nausea, insomnia, abdominal pain, and dyspepsia. If zepirone is available in a country, this could be effective, as it could be a good game changer in a country because of its pro-sexual effect independent of the antidepressant or the anxiolytic activity. The study has shown that 67% of enhancement in the orgasm domain, even the non-responders to antidepressant benefited with zepirone. The zepirone can be effective, especially in tackling the sexual dysfunction, which is quite common with our antidepressants. The next drug, which has been recently FDA approved, is the brexanolone. This is the first drug that has been approved for postpartum depression. It is also a rapidly acting antidepressant, and which is an aqueous formulation of allopregnanolone. It is administered as a continuous IV over 60 hours, varying from 30 mcg per kg per hour to 90 mcg per kg per hour for, as I said, for around 60 hours. Which acts on the GABA A receptors. The side effects are dizziness, sedation, and the dry mouth. And zuranolone is another FDA-approved drug, with the first oral approved treatment for postpartum depression. This also acts on the GABA A receptor. The dosage is only for 14 days, 50 mg orally. The good thing is there are no contraindications with zuranolone. The side effects are same, almost like brexanolone, the somnolence, dizziness, the diarrhea, fatigue, and nasopharyngitis, and urinary tract infections. The JAMA Psychiatry has published the efficacy of zuranolone comparing with placebo. The findings were on day 15, there was significantly a greater reduction in depressive symptoms compared to placebo. Next one is the most discussed one and the most prominent one is the ketamine. The ketamine also called as the special K, the vitamin K, or the Kit Kat, whatever you call it as. The ketamine is not FDA approved. It is also an NMDA receptor antagonist and an associative anesthetic. It constitutes a mixture of the S-ketamine and the R-ketamine. As you know, the S-ketamine is already approved for FDA, approved by the FDA. Even the R-ketamine was also tried as an antidepressant, but because of its advantage of not having a dissociative effect. But the R-ketamine failed during the phase 2 trials, so it wasn't approved. Coming to the ketamine is real. I would personally say it is a game changer in our field of psychiatry, especially in depression, with its rapid improvement. Though it is a short term, it is very effective. But at the same time, the ketamine can have the only thing you need to take care of is it can have a significant effect on the blood pressure and heart rate. And before administration, a thorough checkup, including with routine investigations, should be done along with ECG is recommended. The side effects are the dizziness, the dissociation initially, and the rare laryngospasm. And one of my colleagues have reported that ketamine was associated with vomiting, but I didn't encounter any of my patients still saying vomiting. The various routes of ketamine that can be tried are the intravenous IV, the subcutaneous, the intramuscular, the oral, and the sublingual. If you're trying in any IV or subcutaneous or intramuscular, the induction phase, it is advised is once or twice a week. In the maintenance phase, for once or twice a week for around 6 to 8 doses. Then later you bring the patient to the maintenance phase. Slowly you make it weekly, then you make it bi-monthly, and later you end it up with monthly. Now the ketamine again came into limelight recently after the death of a web series actor, a web series called Friends actor called Matthew Perry. How effective is ketamine? Now, you don't find much studies comparing a drug with an ECT, as ECT is an ultimate option when rest of them fail. But when you find studies comparing ketamine with ECT, I think it itself speaks the superiority of ketamine, at least compared to other drugs. Now, coming to the study, in this study, 403 patients with treatment-resistant depression were divided into 2 groups. One group received ketamine twice a week. The other group received ECT thrice a week. During the initial three weeks of treatment phase, the findings were the ketamine was non-inferior to ECT. But again, on contrary, there was another study that was published by our Indian authors, Dr. Vikas Menon sir from JIPMER and Dr. Chitranjan Andrade sir, and where they have analyzed 5 trials. They have found that ECT had an advantage over ketamine. It was significantly. Now, come next, on another interesting study comparing ketamine with the intranasal esketamine, where the study has found that the ketamine showed a higher short-term antidepressant effect, whereas the esketamine had an advantage of lower side effects. Obviously, the ketamine IV would have an faster onset of action because of its bioavailability. The bioavailability of ketamine is 100%, whereas the bioavailability of esketamine was 54%. Another promising drug which is not available in the country, but in the foreign, is the psilocybin, which is a classic tryptamine hallucinogen, which has a higher affinity on several serotonin receptors, especially the 5-HT2A receptors. Now, the initial studies have suggested that the psilocybin, in combination with psychotherapy, have provided have given a major symptom relief, especially in patients with treatment-resistant depression. And also, the animal studies have revealed that the psilocybin has a low addiction and the physical dependence potential. Now, the safety of psilocybin regarding it has been published in the JAMA Psychiatry, where it has shown that 25 mg of psilocybin was clinically significant in reducing symptoms without any adverse effects. Another study that has been where the psilocybin was compared with escitalopram for depression, where where there was no significant difference could be found between psilocybin and escitalopram, but the incidence of adverse effect was similar in both. The psilocybin patient had reported transient headache within 24 hours of dosing, whereas the escitalopram patients have reported such as anxiety, sexual dysfunctions, etc. So far, in the in the TRD scenario, the current options with reliable efficacy seem to be limited to neuromodulation techniques and to some extent the ketamine, which is quite promising. So the search for gold standard antidepressant medication continues. Thank you for patient hearing. I would like to thank the CME committee and the organizing and our IPS State Branch Secretary, Sarath Chandra sir, and President for giving me the opportunity. Thank you very much.
Thank you very much, Nihal. Your presentation is very excellent. You did very well, and you explored so many molecules. I have still one or two doubts. What is the availability and cost to the patient regarding esketamine, Nihal?
Sir, it's not yet available, sir. It is yet to come to our country.
Is it expensive to the patient?
Yes, sir. It is all the newer molecules are expensive to the patient. Like as of now, like they are like around 5,000 that I've seen in the websites.
Even the new molecules like brexanolone, zuranolone, you said regarding their studies towards postpartum depression.
Yes, sir.
What about TRD?
TRD, they could be effective. Like, I couldn't find studies with TRD, but they are expected because they are rapidly acting antidepressant. You could see the zuranolone or the brexanolone. The brexanolone is given only within 60 hours. 60 hours in 2.5 days, whereas the zuranolone is given only for 14 days. And the results were promising as of now. So that could be helpful in postpartum depression.
Right. Even though it's very rare, how about the rate of surgical procedures, neurosurgical procedures regarding TRD? The ablative limbic surgery, is it going anywhere?
I couldn't find much studies. I couldn't find articles also supporting as of now, sir.
Thank you, Nihal. You have done excellent work. And I invite all the floor members to have their doubts or questions.
Nihal,
Sir,
There are two questions in the chat box.
chat box.
Please read out, sir, all of you.
Nihal, what about magnetic seizure therapy and TDCS?
they are proven effective, but I don't have any experience saying that to about both of them. So like they are proven effective, but how effective it is, can't really say.
The next question is, what is prevalence of serotonin syndrome while treating resistant depression?
Again, the prevalence of serotonin syndrome, again, it depends on the risk factors of the serotonin syndrome for the serotonin syndrome to occur. So like the dosage and depends on how high dosage we use, but I couldn't find studies regarding serotonin syndrome in the TRDs.
Nihal, how much of the difference regarding suicide rate with all other depressions and when compared with only TRD?
The suicide rates were quite high, more than were comparatively high. No, not something. The suicide rates were comparatively high in those with TRD because like most of them had anhedonia and psychomotor retardations. So because those two are the main things that were affecting TRDs and also the somatic complaints, but mainly the marked anhedonia and psychomotor retardation. So obviously they were quite high, and the ketamine was quite effective in dealing TRDs.
Yeah, initially you started with the very definition that most of these guidelines have not included psychotherapy as part of the treatment. That is the reason why these depressions are becoming resistant. I think initially you started with that statement.
Yes, sir.
and you have not covered any of those psychotherapy techniques. Do you think these psychotherapy techniques are any specific for TRDs? Please comment on that.
Uh, Specific, I think I mean the psychotherapies again, like more. I haven't touched psychotherapies because none of the guidelines have mentioned regarding none of the guidelines have mentioned regarding psycho. There are few articles saying that the psychotherapy should be considered, where like CBT should be done along with when you're going with higher antidepressants, or when you're using low dose antipsychotic. That maybe the cognitive behavioral therapy could be tried.
Yeah, I think in a similar way for borderline personality disorders, we have what is called directed behavior therapy and interpersonal therapies. I think all these therapies can be tried, but as you said, the CBT is the one which is done more frequently and more standardized and manualized. Isn't it?
Nihal, two more questions. If partial response, which would be better, augmenting with a second SSRI or fully changed to second SSRI? In your practice, which are the best augmenting options?
In my practice, best augmenting, I generally start with SSRIs first, then give an add-on as SNRI.
Next question, augmentation with lamotrigine is better or with atypical antidepressants like aripiprazole?
I would prefer atypical antipsychotic aripiprazole than going with lamotrigine because of the side effects.
Mr. Chairperson, can I add a few
Sir.
things?
Sir, sure, sir.
Yeah.
Sure, sir.
First of all, Nihal, you have done a reasonably comprehensive presentation. Though at times I think you went on to discuss on depression alone, but not the topic of TRD. But having said that, there are 2 or 3 observations which have come out quite well in the recent times. Now, to start with, the definition itself, TRD. Normally, if you go through the literature, there are 34 definitions of TRD. 34. That means each author during his research has used some, removed some. And one of the major criticism of TRD research has always been non-inclusion of ECT or neurostimulation in their study. And second important thing is for too long period, our hypothesis of management pharmacologically of depression is based on the monoaminergic hypothesis. Unfortunately, we have not looked at other things. One of the recent, that is the last 5 years research, especially you touched on ketamine, the basic hypothesis there is a cyclic AMP mediated intermediate metabolism manipulation. For the sake of this thing, we are running the ketamine clinic we are doing for the last 5 years in Asha Hospital. We have a large data. And of course, Dr. Chittaranjan Andrede's 3 important articles in the Journal of Clinical Psychiatry are very important for us. In fact, Chittaranjan Andrede talks about giving ketamine as a oral drops. You'll be surprised. I have attended a 3 hours workshop. I think Nihal was there at Bhopal when he presented, giving, the dose of ketamine in a glass of water in the morning to the patient. And he proudly says that he has observed so many patients that he is no longer worried about any of the side effects. Now, based on the cyclic AMP, the newer responses is, I think, I would add to Nihal's presentation, is a not yet a very successful molecule in terms of clinical research, but definitely some data is coming. That is the agomelatine combination. You have heard about agomelatine. Regiana is the trade name, and their L-carnitine and agomelatine. Now, this 2 combination is supposed to work not only on the primarily increase of neurotransmitters. A lot of animal studies have shown. There is 1 or 2 double-blind studies. I have just completed one study with escitalopram as a double-blind study. Uh, that holds a promise for a treatment-resistant depression. Now, coming to just one comment on psychotherapy, one of the major comments on TRD psychotherapies is hardly any sample size more than 20 patients are tried. And obviously, the comparative, that is either sitting on the bench or treatment as usual with the other molecule, that comparison also has shown a very small effective size. So I think CBT also is more like a um, style which is accepted, but it doesn't really have a data. And you'll be surprised the effective size in most of these multiple meta-analysis studies of CBT is less than 1.2, which is a very small effective size. So with this, I think the last point I would like to comment is the STAR-D trial. Why STAR-D? STAR-D is a real life patients of us in multicentric trial in which the sad news is for the first molecule, only 1/3 of the patients respond in 8 weeks' time. Adding another molecule, only 13% response. That is either augmenting or switching. The third response is that is the mirtazapine, the cocktail, and all these things. Here, L-throxine. L-throxine doesn't have any value in augmentation. That's a clear statement. But mirtazapine and other things, mirtazapine and escitalopram, the so-called Californian cocktail, though it is empirical, doesn't have a large data. And finally, I would like to close. One of the best molecules, if no molecules work, some people, some seniors sitting here also, or in this conference would agree, tricyclics is the best. Now, if you ask me which is the best for a treatment resistant, I would say I would go back to venlafaxine. Go to 300 milligrams, up to 300 milligrams, watching the blood pressure, not as an augmentive, but as a segmenting. Augmenting, aripiprazole doesn't have a great effective size. Remember, most of the augmenting with the atypicals are the so-called bipolar depression much more than pure major depressive disorder treatment resistance. So this is some of the observations I gathered, but I would congratulate the IPS AP state branch for giving the young stars the limelight, and I wish we continue with the same thing. Thank you very much for your time.
Thank you very much, Dr. Prasad Rao. Always you are giving excellent additions and the superb analysis also. Thank you very much.
Nihal, a small doubt from my side. No, are they actually, when we see why few patients respond, few do not respond, are there any structurally, are they structurally different, more structurally or functionally in the brain? Especially if you take the default mode networks. Are there any real differences between those who respond and who do not respond?
Sir, that is quite a complicated question, to be very frank, because like everybody has their own structure, like based on the genetics plays a crucial role. I've discussed also this with Dr. Bhaskar Mukherjee sir, and even he says that the genes and the brain structure that plays a crucial role about which drug works well.
Very nice, Nihal. Good answer. Any more?
Nothing, sir.
Maybe just I would add one more. One of the thing is that the modern CYP, I mean modern tests of the CYP determined genetic tests are one of the tests I normally use in a patient who is not responding by 12 weeks time. Here what we know is because they give a result of actually they are not giving which drug will work. They give which drug metabolism is affected because of the enzyme system. So in a way, the report would guide you. For example, in a report, if you see in the modern times, there are multiple tests. like my gene test and all these things, they would cost here right now, they are costing in Hyderabad around 5,000 rupees. You get a result. So you know that this patient, it very clearly says that escitalopram is not suitable or desvenlafaxine is not suitable. Remember, this is not based on the blood levels, but it's based on the metabolic possibilities because of the enzyme deficiency. The second thing is, I think in TRD, one of the things which I think Nihal possibly didn't cover so stressful, at least for tricyclics, we need to do blood levels because there is a therapeutic window. Most of the time when you use tricyclics, we need amitriptyline clearly as a window and chlorimipirine clearly as a window. Window means if it's less than 150 milligrams, majority of patients do not respond. That's what found in TRD. Same thing with chlorimipirine, but we don't have it that similar thing to SSRIs or SNRI. And as I said, SSRIs are the most popular ones which we use, but only 1/3 response. So we need to definitely use augmenting. So most of us are use of polypharmacy of antidepressants in treatment resistance. Thank you.
Thank you, sir. Thank you, Prasad. Thank you very much for more making more beautiful. Any more doubts from audience?
Sir, if there is nothing, I request Kishore to propose the vote of thanks.
Good evening, everyone. It's my honor to present vote of thanks on the behalf of IPS AP State Branch. I thank today's speaker, Dr. NG NIHAL, who really gave new insights for the topic treatment resistant depression. We thank Chairperson Dr. R.K. Ayodhya Garu for chairing and moderating session. I thank the CME committee, IPS AP CME committee, G. Ramarao Garu, Vishal Inda Garu, and Ranjit Kumar Garu for choosing the topics and the selection of speakers. And I thank the IPSAP State Branch President, IVL Narasimha Rao sir and Sharad sir and all the other office bearers for being the part of this and really encouraging the young minds to encouraging them and encouraging them to come to the limelight. We thank everyone. And not the least, last but not least, we thank East West Pharma for sponsoring this session. Thank you so much. Thank you, everyone.
Right, sir. Right. Thank you very much, sir.
Thanks, sir. Good night, all of you. Thank you very much.
Thank you very
Thank you,
much.
sir. Thank you
Thank
very
you for
much.
our
Good night.